Today we'll be talking about an overview of the development in imaging and use of ablative energies and how they have developed side by side and complemented each other. Over the period of so many years, we have seen that there has been a huge development in the development of imaging. They have become more precise. They have we saw that in the early 80s with the development of CT scan. The journey has been quite quick, and now we stand using all these things in our daily clinical practice, including MRIs, PET scans, and fusing those images to do biopsies and other interventions in the human studies. We are at the verge of almost incorporating these technologies in our daily clinical practice. This has also seen that there has been a parallel development in the development of energy tools, and they have become more sophisticated, and their use has been from really dangerous ones to they have become more medically acceptable, and some of them are FDA approved. So this journey of development of ablative tools started with cryo, and certainly there have been further developments in specific cryo machines. Then we saw brachy, HIFU, and different forms of lasers which we use today, including interstitial lasers, and now we are using irreversible electrophoresis, and more recently transurethral ultrasound ablation, which is a trial which we just finished for the safety analysis. So are we ready for the time? At the beginning of today, I probably thought going through this presentation that we are, but listening to all the august presenters before me, I think that we are still far away. So image-guided interventions have been used to contour the tumor, delineate our targets, and then monitor them during ablation, and then, of course, for follow-up assessments. And Western has been at the forefront of development of many of these gadgets, which today help us in delivering better care to our patients, including the 3D volumetric images, which are used in one of these systems, which I hope most of you are familiar with, the Artemis system, which is used to scan, plan, and then do these to do better biopsies for the patients. This consists of a robotic system which is kind of integrated with the image, and then with several options available. The range of motion for this allows us the liberty to precisely target the lesion in the prostate gland based on the ultrasound and obtain better biopsies. This imaging modality has further been extended into the use of robotic surgery. We, as surgeons, can see things, and there are things which we can look by, but we cannot see. So there are these ultrasound images which are integrated in a OR suite. Here we have the surgical robot and the patient here, and we have this ultrasound machine which is placed intraoperatively, and then during dissection we can better see where we are cutting. So this system uses a real-time ultrasound technology to kind of define where the scissor tips are and where dissection needs to take place. So this is one of the examples where development in imaging technology has helped the surgeons deliver better surgical results. And things which we could not see before, we can kind of look now through the eyes of a real-time ultrasound during operation, and the oops of surgery, like we know where we are cutting, and then we just cut a little bit more, and there was a little oops there. These oops are probably going to be much more lesser in the future when we use these images during our dissection, especially the robotic system, where we lose the haptic feedback which we are trained to rely on during surgical procedures. And now this haptic feedback is kind of replaced by better visualization, which we have to learn to kind of, substitute for the feeling of the hand. There are emerging hypotheses from imaging pathology fusion, and several types of MRIs which have been talked about have near complete fusion with the real lesion seen on the whole mount histology, and a composite MRI is probably the closest. Of course, there are detection and inter-observer biases with this study. So in this image, we can see the use of dynamic contrast enhanced MRI and robotic intraoperative image. In this image, this is the image which is seen by the surgeon through this console, and when this dynamic contrast image is laid on the view of the surgeon, he can better appreciate where the lesion is and decide to go wider or to preserve the neurovascular bundles in this case. So the integration of imaging with surgery has led to better functional as well as better oncological results. Next. Here we can see this image being overlaid on the surgical view, and we can see that, where the tumor is, and decide to go more wide or narrow depending on the location of the lesion. So we have seen improvements in imaging technologies and how it has helped us in delivering better surgery. If you look at the development in imaging and the use of energy, we are now heralding into an era where more focal therapy can be delivered to achieve similar oncological results. The applications of the energy has been in whole gland ablation, but now more selectively we are seeing emergence of this, the use of ablative energy in focal therapy, and this is all because of improvement in imaging technology. We also have salvage setting in which both whole gland and focal therapies have been applied. The history starts in 1960 when we started using cryotherapy in the open surgical setup, and where the surgeon's finger was placed behind the organ, and it was kind of ablated with this ice ball, and often resulted in quite serious side effects, not to the patient but maybe to the surgeon as well. And of course, the surgeon, this led to abandonment of this technique, and there were several complications. With the development of imaging technology, and we found that it was kind of a perfect storm for the application in clinical use, and we found that fire, again, and about 20 years back it was reported that, if fire fails, try ice. And in this case, we see that percutaneous ablation of cryotherapy again re-emerged into clinical practice, which was abandoned before. Here in this slide, we can see that the previous generation and the new generation cryo machines, and where we can see that they are being applied percutaneously, and better image guidance, of course, lead to better placement of these ice balls, and result in better oncological outcomes. So in this large study, which looked at about over 2,000 patients, in which primary cryotherapy was used to treat prostate cancer, localized prostate cancer, we see that there are about 1,000, at least half of them, slightly less than half of them, have a PSA of less than 0.1. So this does signify that this kind of treatment has has a role in treatment of prostate cancer. However, there are many flaws in this study which we can discuss. Another randomized trial which looked at the lowest stage prostate cancer, in which the comparison was made between external beam radiotherapy versus cryoablation in patients with localized prostate cancer. And at 36 months of follow-up, we find that about similar positive biopsy rates or similar disease progression in both cryo and external beam therapy. but this is for low stage disease, although at the positive biopsy rate at 36 months was slightly higher in the external beam. We again did a similar study at Western, and in this, however, this study was performed on higher stage disease, in which we used either T2C plus or T23B prostate cancer, and both of these received hormone therapy before going on to either cryotherapy or radiation, and if radiation failed, they also received cryotherapy. So these kinds of patients were also included in this study. What we found that, the survival analysis, we found that the radiation did far better than than cryotherapy, and the survival analysis done at 48 months of interval showed that there was only 13% patients who benefit from cryotherapy versus about 40-something in external beam radiation. So this study did show that cryotherapy is inferior to radiation therapy. Another study which was published by our group looking at this time the salvage cryo for biopsy-proven prostate cancer with a median follow-up of about 7 years, and about 52% patients were followed for about more than 10 years. We found that about 40% of them were cured by salvage cryotherapy following radiorecurrent prostate cancer. This is our updated results, and in our updated results also we find that at 10 years and 8 years, with both time periods, we found that the cure rate was about 39 to 40%. This is an overview of other studies which have delivered focal therapy with cryoablation. Some of them have treated hemigland, and some of them had treated the focal lesion only. There are several problems in these, but overall, if we look at them, there is a trend towards increasing number of studies being published today where either subtotal gland or a hemigland or a focal lesion has been treated, and the number of publications from total gland ablation have slightly decreased. Another large database called the COLD database, in which they have treated focal therapy for localized prostate cancer, and although not all patients had biopsy performed, they report a 26% false for cause positive biopsy rate. So we are not sure how effective it is in terms of cancer control, but if you look at the safety profile of these, about 98% are continent, and about 60% have spontaneous erections. So maybe it's too good, but it also has low morbidity. So at least the morbidity thing is there. Another study which looked at the focal therapy in management of organ-confined prostate cancer, and this time in this study they looked at the intermediate risk group of about 62 patients, and about all received cryotherapy, and at 12 months they had about 50 out of 65 negative biopsies, and all the 12 biopsies which were positive had a Gleason grade 6 disease. So at least in this setting, it seems to have an acceptable cancer control rate also. Then changing gears from cryotherapy to HIFU, and it started development in 1956, and in 1980s the first application happened for prostate, and the mechanism of action of HIFU is that it is alternating high voltage ultrasound of the same frequency. They converge at one point with compression and rarefaction, and this results in production of a very high temperature at a very precise focal point. So this type of energy has been used in clinical application for ablating cancerous lesions, and this treatment is always integrated with planning on a ultrasound or functional some kind of functional image. The advantages of this over the cryo is that there is a very tight spatial control of the area which we want to ablate. So the point focus is quite narrow, and the on-off mechanism is very quick. So we can achieve cytocidal temperatures in fractions of a second, and which can be swift on and off depending if the patient moves during the procedure. We can have a better safety profile. So HIFU, for all indications in this study from Munich, they looked at T1, T2 low-risk disease, T1, T2 or intermediate, high risk, and all kinds of settings, including post-surgery, post-radiation, post-hormones, as well as metastatic disease. In this study, they found that the negative biopsy rates, of course, were in the range of 90 to 60, depending on what category of disease which we are treating with HIFU. So overall, we've in this very large study, which looked at transrectal high-intensity focused ultrasound for treatment of localized prostate cancer, and this is probably the largest experience in this category, of including about 500 patients. And we find that the biochemical free response at 5 years for T1 disease is about 74%, and increases as the volume of disease increases. And so giving us an idea that minimally invasive, efficacious and safe localized prostate cancer therapy can be delivered using a high-intensity focused ultrasound for low and intermediate risk patients. But for high-risk patients, this is certainly inadequate. So in summary of the HIFU series, which are to date published, we can say that there are no randomized controlled trials, there are no standardized reporting criteria, as majority of them did not have biopsy, but still it is a safe technique to use and is successful in about 65 to 85% of the patients. So what does the literature say about it? The NICE guidelines published from UK in 2005 put them as they should be an option for treatment, but later in 2008 it was revised that they should only be used in clinical trials. And from Canada, the Cancer Care Ontario recommendations are that this technique is still experimental. So our experience with this technique has been mainly in salvage setting, and to date we have treated about close to about 90 patients. This report included follow-up on about 78 patients. The baseline PSA was 4.3, and about 14 of them had positive biopsy at 6 months. So the positive biopsy rate at 6 months in our hands is about 20%. We have now mean follow-up of about 63 months, and we find that about 32% of them have failed either biochemically or histologically. However, if we look at the complications, the risk of Cleveland grade 3B and 4 complications is quite low. Only one patient had Cleveland 4 complication and one patient had Cleveland 3B complication. So if we look at the use of energies in prostate to date, we think that cryo and HIFU have an somewhat established role, and the use of lasers, electrophoresis, and transurethral ultrasound are still in the early phases of development. The use of lasers has been this is a phase 1 trial which was done at Princess Margaret, in which there is a transrectal probe and the patient goes in the MRI and has this for his focal ablation. And here we find that, with the use of MRI during the delivery of ablative energy, we are able to provide thermography and able to assess the damage which we are creating. So MRI does have a role in delivering of real-time ablative energy, and this has been tested recently in a phase 1 trial which we just finished recruiting. In this, we looked at the safety of MR-guided transurethral ablation. We have a poster on this, and you're all welcome to stop by and have a look at that. Next. Okay, so in summary, if we compare all these modalities and ablative energy modalities, we think that cryo is surgeon-friendly, it is patient-friendly, and has a track record of published data. It relies on ultrasound, which is fusion, and as image coupling can be performed to deliver in focal therapy as well. For HIFU, again, I think it is more surgeon-friendly, it is patient-friendly, and it has a track record which is not as long as cryo, but certainly is emerging. It uses ultrasound fusion and can be used with imaging coupling, and is ideal for focal therapy. The others are still investigational, and time will probably tell us how friendly they are, or how effective and safe they finally are at the end of this. So coming back, we have seen parallel development in imaging modalities and use of ablative energy tools. We have gone from treating the whole gland to now focusing more on the lesion within the prostate gland, and this change has only come about because of advancements in imaging, and as we are now more confident in using them, and of course the development in energy tools which have better safety profiles. Whether we are ready for prime time or not, I think it's too early to decide. Thank you very much.